Okay, thank you very much for inviting me to give this talk on the ESTAMPA study. The ESTAMPA study is a multicentric study of cervical cancer screening with HPV testing and assessment of triage methods. The study is currently being run in 12 study centers in 9 countries across Latin America, and we aim to investigate the performance of emerging cervical cancer screening and triage techniques among women 30 years and older. We do have a second aim, which is to evaluate the feasibility of different approaches that could support implementation of organized HPV-based screening programs in the region. But due to the topic of the meeting, I will concentrate on the first aim. A bit on the design, that we aim to recruit or to enroll 50,000 women aged 30 to 64 years of age who are undergoing HPV testing and who test positive for either test go to colposcopy, and those negative exit the study to routine care. At colposcopy, 2 to 3 biopsies of suspected lesions are collected, and those who have CIN2 or worse lesions are treated with LEST, and those with suspected cancer are referred properly. After treatment, women exit the study again. Those who are negative do not have CIN2 or worse lesions or had a negative colposcopy, because we do not do random biopsies on colposcopy. They are all recalled for a second visit at 18 months with an HPV test. At this moment, no pap smear is repeated, and those who are HPV positive again have colposcopy and treatment as needed, and those who are negative or who do not have CIN2 or worse lesions exit the study. At the point of exit the study, we give women a set of instructions to go on to regular care to avoid any misunderstanding on how to proceed afterwards. And for women who are treated within the study, the majority of them are going to be followed up by the same clinicians that are involved in the study, as women are part of the coverage area of the hospitals where they work on. In our study, we have 2 main study outcomes, which are high-grade squamous intraepithelial lesions using the last criteria, which includes confirmation of CIN2 with P16, unreviewed histology, which is done by an external panel of experts, and CIN3 plus on local histology. We have a secondary outcome, which is CIN2 plus on local histology, given that we use the cutoff point for treatment is still CIN2. We will count as study outcomes cases that are detected at entry at the 18 months visit. However, for this presentation, I will focus on the CIN3 lesions detected at entry, which are based on local histology results. We envisage to evaluate a number of triage tests, and following the talk by Sylvia, I could see that this is of relevance. So we think we will evaluate techniques that are cytology-based, visual-based, and molecular-based, and also some strategies that we think could actually benefit a larger proportion of women. For the molecular testing, we do collect a set of samples at the screening visit in order to simulate a reflex testing whenever possible. All triage tests, with the exception of PAP, are not used for clinical management. The molecular testing is usually done locally, but sometimes it is done in regional hubs or in expert centers outside the region. And not all the tests or strategies are done in all the centers. So for instance, visual inspection is done only in 5 countries which they were willing to assess BIA. And HPV 16-18 genotyping is done only in centers where COVAS was used as a first screening test. So the data I'm going to present covers women enrolled until April 2020, though I have to say that since February, due to the pandemic, most of these numbers have not changed. At the time, we had enrolled more than 40,000 women all over the region, but this is the number with HPV results available for analysis. 14% of them were HPV positive, and this has been a consistent prevalence of HPV infection in the whole ESTAMPA study population since the start of the study in 2013. and 91% of them had already attended colposcopy. So the data I'm going to present is based in this group. However, as mentioned before, not all the study centers perform all the tests or have data on all available triage techniques. So I will present data with different denominators. So I will start with the PAP. And the PAP was done at all study centers because although in some countries in Latin America, HPV testing is already included in national cervical screening guidelines, it may not yet be implemented or may not be implemented nationally. That's something we all know will happen. And then there are many other countries that are not even considering HPV testing in the guidelines yet. At the time of the smears arriving at the laboratories, the HPV status was totally unknown. So they arrived with a number of smears that arrived from different centers and not for research purposes. We decided to classify the laboratories by whether they were public or private and whether the interpretation of the smears was done only by a cytotechnician and confirmed by a pathologist, or it was only done by a pathologist, as it happened in some of the labs involved. We thought these two characteristics were relevant in our context to see if the performance of PAPA's triage was influenced by either of them. I also have to note that one of the centers, which was a public health laboratory with large income of smears per day, the smears from only HPV arrived and they were prepared and interpreted, but the smears from HPV negative women were not sent to the laboratory because of the local investigators deciding to do so. So for PAP, we had 4,661 HPV positive women who had PAP results at the time of analysis. And the diagnosis of PAP, as you could see here, varied from 70 PAPs that were unsatisfactory to 253 with HSIL diagnosis. In this population of 4,661 HPV positive women, a total of 466 CIN3 cases occur, and of those, PAP was able to detect 251 at the ASCUS cutoff. So that gave us an overall sensitivity of 54% with a specificity of 86%. Here I present the laboratories classified according to the characteristics that we use, and although they are grouping each of these lines, we could see that the specificity didn't vary that much. And when we further look into each of the laboratories one by one, the specificity, as expected, didn't change much. However, the sensitivity, particularly on that laboratory where only the smears from HPV positive women were interpreted, the sensitivity was significantly higher than the overall sensitivity and the sensitivity of all the other labs, reaching to 70%, which is quite high for a Latin American environment, I would say. The next strategy I wanted to show you was the use of a repeat HPV test. This is the job of one of our colleagues here at IR, who suggested that this could be used as a triage of HPV positive women in order to reduce the referrals to colposcopy and to concentrate in women that are higher risk. So for this analysis, we included 426 HPV positive women who actually attended the colposcopy visit and had results for the positivity or for HPV testing in the colposcopy visit. We took advantage of our study design by which at entry, we do collect the preserved samples with a cytobrush, and at colposcopy, due to clinical reasons, we collect a swab, but it's also washed in preserved. Here I show you the median time between the two visits, the screening visit and the colposcopy visit, and 50% of women attended this colposcopy within 1.57 months, and the majority of them attended that before 2.5 months. Also, of 62% women that turn out to be positive at the colposcopy visit after being positive initially, the majority of the cases of CIN3+ occur. leading us to a sensitivity of 86% for this strategy of a short-term repeat test with a limited specificity of 42%. We further perform a stratified analysis by age and by the time between the two tests, and we could see a slight non-significant increase in sensitivity as age increases in women over 45 years, and a slight increasing trend in the sensitivity of the strategy when the test is done later on. I also wanted to show results on the HPV 16-18 genotyping, and this is based on the results of 13,840 involves two tests as in primary screening. One was Harry Capture 2 and the other was COVAS, and this is the group of women who had COVAS as initial test. 1,605 of them were positive on COVAS and had results for 16 and 18 HPV types. Of them, 28% were positive for 16, 18 or both types, and 72% were positive for any other high-risk type in the COVAS cocktail. Among those who were positive for 16 plus or 18 plus, 60% of CIN3s happening in this whole group occur versus 40% in the other non-18, 16, 18 high-risk types. We further decided to apply PAP smear to see whether adding PAP, the sensitivity of the overall strategy would increase. So then the sensitivity of using HPV 16-18 was 60% with a specificity of 76.5%. And when we add the PAP on those women who were non-16-18 positive, the sensitivity increased 15% with a reduction of 10% in specificity. But as we go up on the cutoff of PAP, the sensitivity improvement was less, but so was the reduction in specificity. I also wanted to show results on VIA, and I think this is of interest after Silvia's presentation. For us, most of the countries that are involved in the STAMPA study are either middle or upper income countries. However, even in these countries, we all know that there exist large inequalities in access to care due to many reasons, starting by geographical difference, cultural differences, and mainly due to non-availability or capacity building in all the regions within a country. So we decided to evaluate visual inspection as well. In a group of 1,994 HPV positive women in Bolivia, who were screened in Bolivia, Colombia, Honduras, Paraguay, and Peru. So again, we take advantage of our study design to actually evaluate VIA at the colposcopy visit after a positive screen with HPV. And at this visit, first, a trained examiner on VIA will enter the clinical room, but the colposcopists wouldn't enter. The examiner will perform VIA, note the results and observations, and leave the room. And then the colposcopists will perform the colposcopy. However, in some instances, the nurse actually who did the VIA was the assistant nurse on the colposcopy. And so under protocol, they should not have discussed or disclosed any of the observations. In this group of 9,944 HPV positive women, 182 CIN3 plus occur. So here I present the results of VIA positivity by disease status. First of all, the positivity of the test was about 55% among HPV positive women. With 3% of them being inadequate, and we could see here by age that as expected, that rate of inadequacy starts at about 50 years and above. Of 182 CIN3 cases that happened in this population, 156 were detected by VIA. giving us a sensitivity of 87% of VIA among HPV-positive women with a limited specificity of 50%. We performed an additional analysis by age, and we could see a small increase in the sensitivity in women over 45, non-significant though, but a significant increase in the specificity. Further on, we look again at the results by age. In women over 50 years, of 24 CIN3 cases that happened in this age group, 20 were detected by VIA, and of 8 it is recommended to have VIA up to 49 years of age. Maybe there is still some benefit on older women. I finally wanted to show you the validation of a new test, which is the 8 HPV type OncoE67 cervical test. Based on the commercially available Arbor beta test, which actually detects oncoproteins for HPV 16 and 18 and has shown to have high specificity for CIN3 plus detection, we team up with Arbor beta, the developers, and under an NCI grant, we decided to go on and develop a new test which will include oncoproteins for 8 HPV types based on a previous prototype developed by Arbor beta, and this is the new test and the new prototype, which actually includes three strips. The first one with oncoproteins for 16, 18, and 45, the second one for 31, 33, and 35, and the third one for 52 and 58. So we team up, develop the test, and I will show you what happens after. So we validated this new test using a convenient sample of the STAMPA study of 872 women. This is a convenient sample and of course doesn't represent a screening sample, as the number of cases of CIN2, CIN3 and cancers were enriched compared to a general screening population. Furthermore, 98 of these cancers, 60 of them were recruited in cancer centers, as we didn't have enough cancers at the time of the initial validation. We use initial samples collected at the initial screening visit and at the colposcopy visit to evaluate this new test, particularly a dry swab that was the sample used for the evaluation of the oncoprotein test. The sensitivity of the test came up to be 60% for CIN3 plus and 73% for cancer. And we saw a non-significant increase on the sensitivity at age 45 or further. We look also at how many of these oncoproteins actually were the main drivers for the overall sensitivity of the test. And we found that for both disease thresholds, oncoproteins for types 16, 45, 18, and 52 were the main drivers of the sensitivity of the test, and that in our population, oncoproteins for HPV types 35 and 58 were of no relevance. We tried to look at the specificity of the test, but being a convenient sample, we decided to look better to the percentage testing negative for the test among different groups that were selected in the convenient sample or were considered free of disease at the time of that. So overall, for all of these three groups, the percentage negative was 81%, but it varied by a strict test, by a strict line of the test. So for both oncoproteins 16, 18, 45 and the strip for 52 and 58, the overall negative percentage was above 95% more or less. But for the one that included oncoproteins for 31, 33, and 35, it was lower, having an impact on the overall negativity or so-called specificity of the test. We discussed this with the developer, and we realized that there could be potential false positive for oncoproteins 31, 33, and 35, and the developers suggested that there could be some cross-reactivity, and they went on refining the test. We then retest some samples, not enough, I would say, but with the few samples that we retested, we could see that the percentage negative increases further. And I also want to highlight that although the analysis here is presented by a strip test, when we look at these percentages among women per oncoprotein included in the test, so that is the 8 oncoproteins one by one, all these percentages were above 95%. So in conclusion, I have to say that I have shown you four technique strategies for triage of HPV positive women, and of them, 2 of them, BIA and repeat HPV test, had higher sensitivity but very limited specificity. And on the contrary, PAP and HPV 16/18 had sort of limited sensitivity with higher specificity. The PAP sensitivity, although was laboratory with the smears only from HPV positive were interpreted, biosensitivity was very high, possibly due to three things actually. The first one is that there were very few examiners. The second one, that examiners in Peru and Colombia are very well trained on BIA and they use BIA daily. The third one is that there is possibly correlation on results between the BIA and the colposcopy results at the time in one center. So this is all undergoing a further revision. However, after doing several analyses, the sensitivity of BIA was not reduced a lot. Adding PAP at the ASCO threshold to triage HPV non-16/18 positive increased the sensitivity of the HPV 16 strategy based on COBAS by 10% to 15% as we go up the line of the PAP threshold.
Are we close to the end? We're running out of time.
Yeah, I'm finishing. And finally, I wanted to say that repeat HPV tests may be considered to avoid clinical visits, especially if it is done by self-sampling, despite the low specificity in current circumstances like the current pandemic. Finally, no single triage test so far has shown a final answer, but we keep on going and doing more evaluation, PAP when HPV status is known, BIA at different points in the screening. We are performing dual stain cytology in a hub in Costa Rica. We are going to do sequences soon for HPV full genotyping and methylation assays in the NCI. We are evaluating colposcopy as triage of HPV positive that is needed for needs further assessment. I show you preliminary results from the 8 HPV OncoE67, and we will continue evaluating it in a large screening population as a standalone test and as a triage test for HPV positive women. And finally, I wanted to say that all screening techniques and strategies will be evaluated along and in combination using HSIL, which is the main outcome of the study, under the last criteria, including cases detected at initial and at 18 screening visits. And I thank all the sample investigators and the organizers for inviting me. Thank you.